Welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak, an associate professor in the School of Integrated Health Sciences at the University of Nevada, Las Vegas, and your host for today. Today, I am joined by Dr. Rachel Koldenhoven Rolfe, the senior author of a recently published systematic review and meta-analysis research article entitled Gait Training Interventions for Individuals with Chronic Ankle Instability in the May edition of the Journal of Athletic Training. Dr. Koldenhoven Rolfe is an assistant professor in athletic training at Texas State University, and her research interests involve measuring biomechanics for individuals with chronic ankle instability and using impairment-based techniques to improve patient outcomes. Thank you so much for joining me today.
Thanks, Kara. Thanks for having me.
So, Rachel, the first thing that I want to know is why was now the right time and what inspired your team to conduct this systematic review and meta-analysis?
Yeah, that's a good question. So at Texas State, we have a master's in athletic training program, and our students are expected to do research projects. And so we kind of were spitballing some ideas and talking about areas of interest. And one of my students said she was interested in knowing more about gait training and how she could use it in clinical practice. And so that fits really well with what I do. And so I suggested, let's look at what gait training has been done in chronic ankle instability individuals and, what studies are out there. Are there enough for us to make a systematic review? And then if there's enough, maybe we can do a meta-analysis as well. And so for her, it was a question of what can be done for these individuals with chronic ankle instability besides just traditional rehab techniques, and maybe how she could implement it into her clinical practice. And for me, it's my area of research. So it worked out really well to pair up with this student to do that.
So tell us a little bit more about how were you guys able to do a meta-analysis versus just a systematic review? How did that decision go?
So for the systematic review, that's typically done by doing a broad literature search and identifying articles that meet the criteria. So the big hitters for this project were people with chronic ankle instability, some form of gait training, and biomechanic outcomes for walking. And so those were our big key areas we were looking for research articles in. And so to move from synthesizing those studies that met the criteria, we look for studies that have plantar pressure or center of pressure. That could be the outcome of interest. If multiple studies report that measure, we can then combine those data and do a meta-analysis. So the meta-analysis is even stronger than just an individual study. And so that's what makes this project really unique and special, as we were able to take a lot of research and compile it into a meta-analysis for strengthened interpretation of results.
So tell us a little bit about the variety of interventions that were performed in the included studies. There was kind of a bit of variation.
Yeah, so in my mind, we have kind of two categories, if you will. So one category would be using devices. So things that a participant would wear that aren't necessarily giving you anything and giving you any information in return. You're just responding to the device. And then the other category would be biofeedback. So that's taking some outcome measure and providing the patient with feedback either immediately or after the fact about that outcome measure. So taking someone's ankle position and giving them a beep if it's not in the desired range. And so within our devices, we had things like destabilization sandals, multi-axis devices, destabilization boots. And then within the biofeedback category, we can break that down into even more categories. So with the biofeedback, we have auditory, meaning they got a beep or a tone was sounded when they were not in a range that was desired. We had visual biofeedback. So that would be providing any sort of visual cue, whether that be with colors or shapes or shifting a laser, anything like that would be considered visual biofeedback. And then the last of the biofeedback categories is actually called haptic biofeedback. So that's providing a tactile or vibration sensation to some area of the body. In this case, it was to the lateral malleolus or the lateral ankle. And so those were the types of feedback and devices that were used. And then the studies also varied greatly on the number of sessions. So some were one session just saying, hey, can we make a change while they're wearing it or using the biofeedback? And then other studies were up to 8 sessions and had a baseline visit and a follow-up visit, and all of the biofeedback was given within that time frame. So a wide range of studies were definitely included in this systematic review.
So then how do you make the decision and can you give us a definitive answer? Rachel, does it work?
I would argue and say, yes, it works. It just depends on what you're doing. So typically, when researchers are creating these gait training protocols, they're looking at a measure that an individual with chronic ankle instability has a problem with. So, for example, individuals with chronic ankle instability often walk on the outside of their foot or on the lateral aspect of their foot. So, with the plantar pressure measures, the location of center of pressure, so where that pressure is along the bottom of the foot, that measure can be impacted based on how the foot is positioned and how the person's weight is shifting over the foot. And so the gait training for those individuals with the lateral center of pressure is typically going to be focused on let's shift that pressure medially. And that was really the key outcome measure that was performed in most of the studies. And so that's why I'm kind of harping on that outcome measure specifically. So when the researchers are creating their biofeedback or they're using devices, the goal is let's shift that pressure from lateral to medial. And the way that they achieve that can be through a variety of ways. And so our meta analysis showed that we could shift that location of center of pressure for the first 90% of the gait cycle. So that was really encouraging. And that was just from single session studies. The studies that have additional sessions, so 5 or 8 visits, those studies also showed that the gait training improved the outcome that they were targeting. So, all in all, I would say most of the time, gait training works as long as the focus is on the specific measure and the gait training is targeting ways to shift that measure specifically.
So, from what you guys found and evaluated, what are your recommendations for standardization in future clinical research or clinical practice, even?
Yeah, I think the standardization piece can be a bit of a challenge because we want to treat each patient individually. So, especially in clinical practice, you hopefully know your patient. You can see maybe, oh, they're walking with a lot of ankle inversion. I can target that because I can see it. Or I look at the bottom of their shoe and I see they're riding the outside ridge of that shoe. Okay, how can I shift that? And then looking at the studies that have been done that have used those outcome measures and maybe coming up with a creative way address the issue for your individual patient. I think researchers are trying to find ways in which we can improve gait. And then now moving forward, hey, how can we move from the research lab to more clinic friendly gait training interventions? So there's a lot of work to be done, but I'm not sure if it can be standardized at this point.
So, let's talk more about the next steps in research. I mean, what do you think we really need to push the needle forward? Do we need more longitudinal studies, multi session interventions, something else entirely?
Yeah, I think right now the gait training is kind of in its infancy for chronic ankle instability. So a lot of those studies were one session. I think taking those interventions and making them multi-session, whether that be 4 sessions, 8 sessions, is important so we can determine what are the impacts as we do this more routinely, and then having longer term follow-ups for those studies specifically. So right now there's not really many studies that show what's happening at 1 month or 3 months after these individuals stop doing gait training. So we can answer really well, hey, this is what happens while they're doing gait training or within a 72-hour window, but those longer term follow up studies aren't there yet. So definitely diving into that. But I also think it's important for us to understand from a dosage standpoint, how many sessions do we really need? How long of a session do we really need to be impactful? Because we know athletic trainers are pressed for time. It's hard to find 30 dedicated minutes to give to one person while they're walking on a treadmill 8 times. So, I think researchers are really focused on how can we determine how much gait training you need? And then for me personally, my biggest push is how do we get away from really research heavy equipment based studies and give clinicians something tangible to use in the clinic or to provide their patients to take home with them. So I've recently conducted a pilot study where we basically used no tools. It was verbal feedback and a little bit of visual feedback using tape. So very simple AT clinic based methods. And so I'm hoping to look at the results from that and publish those and maybe even get a grant to further that line of research because I think it's really important. So uh,
I'm pretty sure every AT can find tape somewhere.
I hope so. And if not, every AT hopefully can provide verbal cues. So
Yeah. Yeah. One of the things that we've seen with the gait retraining for things like tibial stress fractures is a ramp down period where we're taking away the feedback. Did any of the studies look at that, or do you know if is that being done?
yeah, so actually, one of the studies included was my doctoral dissertation study. And with that study, we had 8 sessions. The timing of those sessions ramped up. So the first session was, I think, 8 minutes, and we went all the way up to 20 minutes at the fourth session through the eighth session. But when we started getting to that second half, the amount of feedback that those people were receiving came down. So for the first 4 sessions, they received feedback the entire time. So every minute they were walking, they were getting some sort of biofeedback. Then in those later sessions, we were really trying to tone it down. So take the feedback away gradually so that they wouldn't be reliant on that as they move forward. So I know that my study did that. I can't remember if it's included in the systematic review or not, but some other studies have also used similar methods where the first few sessions are full feedback or full device usage and then tapering back as you move forward. So, um, definitely important. And I think can be used across multiple lower extremity gait training interventions, not just chronic ankle instability. So,
So, if a clinician is seeing this and hearing this, what would be some recommendations for those clinicians that want to potentially begin incorporating gait retraining strategies into their clinical practice, and they might not necessarily have the devices that you guys looked at or that were covered in this?
yeah. So, I definitely think the studies that were included were very heavily reliant on equipment that was custom made or research only. I will call out my own study in this. It was very reliant on research equipment. So unless you've got, a $250,000 biomechanics lab, you can't really access that. So I think for clinicians within these studies, there's a lot of instructions such as avoid walking on the outside of your foot such that you hear the tone. Well, okay, maybe they don't hear the tone from a biofeedback device, but you could say, "Oh, you were on the outside that time. Try to walk on the middle ridge of your shoe. Avoid walking on the outside." Is it perfect? Is it evidence-based? Not necessarily, but I think it's supported by what we're doing in these studies to say, I can translate what's happening here and try to make it clinically appropriate because I don't have access to these devices. And when clinicians are doing that, I would highly encourage them to be really engaged with their patient. So asking them, how does this feel? Is this making it easier when you're not doing this? Is pain going down? Or is this causing more problems? And if it is, then maybe we don't need to pursue that. I will also add that I don't think every person with chronic ankle instability needs gait training. So sometimes we have people with chronic ankle instability who walk on the treadmill and they have biomechanics that look like a normal person or a healthy person who hasn't had an ankle injury. And so I would argue that gait training might not be useful for that individual. And so if they don't need it, don't do it.
Rachel coming in with the hot takes, right? Don't have to do every
I'm
single
trying.
intervention. What?
Yeah, even
um,
the ones that I prefer.
what's one thing about gait biomechanics in this population of chronic ankle instability that you feel like is misunderstood or even underappreciated?
I think when I've had conversations with either our athletic training students or with clinicians, there's this misconception that gait training is hard or it's very complicated. Yes, it can be complicated in the research studies because we're really trying to show that one specific thing works and causes something. So we have to be really stringent on what we can and cannot do there. But I think when you're practicing clinically, you get to have this as part of your toolbox, and it doesn't need to be scary. It doesn't need to be complicated. As I mentioned earlier, it could be something as simple as a verbal cue or just teaching the individual, like, don't walk on the outside of your foot. You might be more likely to have that feeling of giving way or maybe even an ankle sprain. So if we can avoid that dangerous position, then you might feel better and you might have less giving way or something along those lines. So it's not scary. It's not overly complicated. You just have to get creative in translating the research to clinical practice.
And what are you really excited about as far as moving this research forward?
Yeah, I am very excited about the pilot study that we just did. Some promising initial results with very simple, very clinically friendly tools. I am curious to see how much we need. So I really want to know more about the dosage. How much time does it really take? And I think even something, if we're really pushing the needle, that might be cool to do is see if we just give you an initial training session and we send you home with some at home instructions, if you will, would that even be, would that be enough?
One last question. What did your student think about the process? Are they completely turned off by research or did this impassion them?
I think if you asked them during the process, they would have told you one thing, that it was very overwhelming. It's a lot of moving parts and it's a lot of there were 13 studies included, so it's a lot to sift through, a lot to grade, and then, creating all of the tables, recreating the tables to get them the way that you want them. It's a lot of work and it's a lot of time, but I do know that Christine is her name. So she's the lead author on the paper. She did learn a lot and she says she tries to use it in clinical practice when she can now, even as she's graduated and moved on and doesn't have to say these things to me. So that's really nice. But I think it's a really big undertaking, especially for a master's student, but she's a student that was very organized, and so systematic reviews are perfect for those students. And then in full disclosure, we finished the meta-analysis after she graduated, so I finished doing that portion, so she wasn't burdened with all of the fun statistical analyses there, so we worked together really well, but it is definitely a large undertaking and a labor of love to conduct a study like this. So,
Oh, and shout out to Christine and thank you again for her willingness to move this forward. And anybody who is interested, this manuscript is available open access through the Journal of Athletic Training, as is all of the journal's offerings. And again, thank you so much for joining me today, Dr. Koldenhoven Rolfe.
yeah, thank you so much for having me, and thanks to all the people who contributed to this article as well.